I teach all my residents, when I teach residents, that my favorite instrument is my second hand, right? So my left hand is my favorite instrument. It's like the most versatile. It's attached to me. I've got it with me all the time. So my non-dominant hand is my favorite surgical instrument. But one that can be sterilized is, so I use this soft tissue forceps we call it a Pauphite forceps. Some sterile processing people call it a Manhattan forceps, but it's a soft tissue forceps. It's kind of fatter. It's got a tying platform. It's got 2 teeth on one side and 1 tooth on the other. And so it's super versatile.
From the basement to the boardroom, from ideas to innovation, you're listening to the Beyond Clean podcast, the central nexus for the people, processes, and products that are pushing the sterile processing industry forward. Each week, you'll encounter diverse perspectives from subject matter experts across the country and around the globe. Frontline technicians, CEOs, engineers, and entrepreneurs with a common goal to help you fight dirty. Every instrument, every time. Whether you are tuning in for education or inspiration, we're glad you're here. Now, turn on those washers and turn up the volume. It's time to go beyond clean.
Joining us today is Dr. Jill Melicher, Ophthalmic Plastic, Orbit, and Reconstructive Surgeon in Minneapolis, Minnesota. And Lindsay, you brought this guest to us today. By the way, it's good to have you on the podcast with us.
Thank you, Hank. It's been, I was thinking back, I think the last podcast I did was the first couple of months working with Beyond Clean. So it's almost been 4 years.
That's crazy. Yeah, that's crazy.
Since the last time I was on the podcast. Yeah. So it's great to be back.
Yeah. 4 years, a ton of seasons, a ton of downloads. We just, at the recording of this show, we crossed over last month 1.1 million downloads. Kind of crazy.
A lot of downloads.
Yeah. A lot of stories, a lot of insights. But, the one today with your doctor, I'm really looking forward to. It's not every day. Like, we talked to a lot of surgeons. It's not every day that we get to talk to our own surgeons.
Our own surgeons. I would be lying to you if I said I wasn't shaking right now in preparation for this interview, because it's very meaningful for obvious reasons. I'm really excited to get into this conversation.
All right. Well, let's not make anyone wait any longer. Stay tuned with us, and we'll be right back with Dr. Jill Melicher.
I'm Justin Poulin.
And I'm Hank Balch.
From 17 Studios, you're listening to Beyond Clean, the global voice of sterile processing.
And joining us now is Dr. Jill Melicher, an ophthalmic plastic, orbit, and reconstructive surgeon from Minneapolis, Minnesota. And, we're going to get a little personal today in this interview, Dr. Melicher, but not necessarily with you as much as my co-host today, Lindsay Brown. But before we get into all that fun stuff, welcome to Beyond Clean. Thank you for sharing a little bit of your time with us today.
Thank you for inviting me. I'm excited to be here. This is my first ever podcast, so I'm excited to share it with Lindsay.
I'll tell you what, you picked a good podcast to do your first podcast on. And, you're actually wrapping up a full season that we're doing spotlighting surgeons. And there's been a great diversity of, conversation insight. We've talked trauma. We've talked about residency. We've talked about training new surgeons. We've talked about the data of instrumentation. But, we haven't really connected the patient piece of the puzzle, and that's going to be a big theme in today's episode. But before we get into that, I'm wondering if you could give us a little bit of background about yourself, and in particular, what drew you to eye surgery in particular, because you got a lot of options coming out of med school. So what about eyes drew you in?
Absolutely. Well, I grew up in Fargo, North Dakota, and I, typical life. I had an older sister and mom and dad, and attended college locally at Concordia College in Moorhead, Minnesota. And I knew early on that I wanted to do some sort of science. I was interested in science from a young age. It all stems back to in 8th grade, I dissected a fetal pig, and I'll never forget bringing that fetal pig home and laying it on my kitchen counter and dissecting my fetal pig on my parents' kitchen counter. And really, it's like the rest is history, sort of. But I had a keen interest in science early on, specifically chemistry and anatomy and physiology. Went on to undergraduate school at Concordia, and one summer I did research on cow kidneys. I fed those cow kidney cells sugar, water twice a day all summer for 3 months. And at that moment, I knew I needed to be a doctor and not a lab scientist. And so I applied and fortunately was accepted into medical school. And, early on, and you probably heard this from other docs too, you really have an inkling about whether or not you're surgically inclined or you want to do traditional medicine. And I knew basically from the get-go that I was destined to become a surgeon. I love to work with my hands. I like putting things back together. I'm a big puzzle person, and I like art as well. And so I think the combination of all of those things really piqued my interest in surgery. I also loved the anatomy lab. I loved dissecting. I could spend hours in the anatomy lab just doing little intricate nerve dissections. And so I really knew early on I wanted to be a surgeon. I actually went to medical school thinking I would do OBGYN, and now I'm an eye surgeon, which is like totally different fields. But, I'm a firm believer that mentoring matters, and I had some great ophthalmology mentors in medical school. And my dad was an optometrist growing up. And so I sort of was like, well, my dad does eyes. I'm not going to do eyes. My grandfather was an optometrist again. He did eyes. I wasn't going to do eyes. And here I am. But I had a great mentor in medical school who said, come take a look at what I do. And I was a little bit worried about trying to balance. I knew I wanted to be a mom, and I was a little bit worried, truthfully, about trying to balance a surgical career and being a mom. And it was important to me to do both and do both well. And so this ophthalmologist said, come take a look at what I do, and the rest is history.
That's incredible. You mentioned OBGYN. Were there other specialties that sort of piqued your interest as you were trying to land on what specific specialty you would wind up in?
Yeah. So I realized early on that orthopedics was not for me.
What was that moment? I'm curious. What was that moment?
The bone marrow spewing out of the femur that got me. It was the only surgery I felt like fainting in med school, but that was it. They were, putting the implant in for the knee replacement, and I was done. I knew ortho was not for me. I thought about plastic surgery. I thought about full body plastics. I thought about ENT. And both of which have really intricate, detailed operations. I loved cardiothoracic surgery, but I didn't know if I could do hearts forever. There's a lot of tragedy in cardiothoracic surgery. And so ophthalmology really melds like a happy specialty. Most of what we do is wonderful, exciting, and gift of sight that we can provide. Some of what we do is not, and we'll talk about that a little bit later. But I really wanted also the longevity of getting to know my patients on a long-term basis, and that's part of what we do as well. So yeah, ortho was out, ENT was in, and I landed on eyes.
That's amazing. Now, Hank mentioned your title being an ophthalmic plastic orbit and reconstructive surgeon. That's a mouthful, first of all. Yep. My goodness. What are the most common cases that you typically see in that role?
Yeah. So I did a 4-year ophthalmology residency, so a year of internship and then 3 years of ophthalmology training. So I trained for surgeries both in and around the eye. I decided that I wanted to specialize in the soft tissues of the eye socket and then the tissues around the eye. And so that led me to do additional fellowship training. So I did 2 years of additional fellowship training we shorten it to oculoplastic surgery, but yeah. Right.
And now you tell me.
And so I pursued fellowship. And part of the reason I did that was because when I went to ophthalmology residency, I really missed the general medicine and surgical principles of everything that I had spent my whole life training for in medical school and internship. And so what I do now gets to really blend a lot of general medicine and general surgical principles and ophthalmology. And so I get kind of the best of both worlds there. So I did 2 years of additional training at the University of Iowa hospitals and clinics. And it was really the best 2 years of my life. It's funny, in medical school, you think that those 4 years are just going to be so instrumental in shaping you who you are. And then you get to residency and you think nothing can be better than this. I'm really excited about what I do. And then you get to fellowship. And it's sort of like I spent my whole life working towards this moment. And I am learning an incredible amount and working my tail off, but I just loved every minute of it. So during that period of time, we learned how to do reconstructive work around the eyes. So and cosmetic work. So a lot of what I do is upper lower lid surgery, both for function as well as cosmetic reasons. I limit my surgery to the mid face up. So I do cheek lifts and forehead lifts. And then I do a lot of reconstructive work as well, both in children, so with congenital droopy eyelids or tear drain reconstruction, and then in adults, if they have trauma or tumor of the eyelids, I rebuild and remake eyelids that function and both function but also have form. And then I do eye removal for both trauma and tumors, and then reconstructive work of the eye socket for both trauma and tumor as well.
That's fascinating. I can't help but wonder, what do you reconstruct an eyelid with?
Yeah, other tissue around.
Where do you, around the eye or around the body?
Both, actually.
Okay.
So it really depends. So if we are dealing with a burn patient that has had full facial burns and sometimes full body burns, we use whatever skin we can find to remake eyelids. But most of the time we do regional and localized flaps to try and move tissue around to create an eye. So like a lower lid, if we're missing a lower lid, we remake it from an upper eyelid. If we're missing an upper eyelid, we remake it from tissue around or the lower lid.
Okay. Fascinating. Wow. As you know, a lot of the folks tuning into this interview are sterile processing professionals, and they live and breathe surgical instrumentation. And I'm curious, with all these surgeries that you do you have a favorite instrument or a favorite couple of instruments that you just love using, either based on function or just because they're cool eye instruments that you get to use?
I teach all my residents, when I teach residents, that my favorite instrument is my second hand, right? So my left hand is my favorite instrument. It's like the most versatile. It's attached to me. I've got it with me all the time. So my non-dominant hand is my favorite surgical instrument, but one that can be sterilized. So I use this soft tissue forceps we call it a Paufic forceps. Some sterile processing people call it a Manhattan forceps, but it's a soft tissue forceps. It's kind of fatter. It's got a tying platform. It's got 2 teeth on one side and 1 tooth on the other. And so it's super versatile. And you can use it on the thin skin that overlies the white part of the eye, the conjunctiva, or you can use it on the thick skin of the eyebrow or the forehead. And so it's very versatile. That tying platform's nice for the little tiny sutures that we use if we're going to do an instrument tie. And so that's like my all-time favorite instrument that can be sterilized.
Amazing.
So, Doc, we've had a lot of conversation around instruments, obviously, in this season from surgeons, and they're so critical to what it is you do. Like you mentioned, all the training that you go through to become a doctor. A lot of that training is, practicing around instrumentation and getting better at that. But in some sense, you're kind of only as good as the tools that you have in your hands. Obviously, your hands are the main tools, your hand in your hands. But when it comes to instrumentation for the eyes, those things are small, they're complex. The smaller and complex instruments get, the easier they are to be damaged or to miss, quality issues in the process. In your experience from the surgeon side, what have you seen that's kind of nuanced, the eye instruments that make it into your hands? What are the preferences that you want to see out of your instrumentation? Any particular challenges that seem to come up through the years as you engage with that?
Yeah. So, we talk about this a lot. We have our own surgery centers. And so we have sterile processing folks that work with us. And there are so many nuances to those little instruments. And specifically the tips of our instruments are critical because if they don't meet, they don't function. But it's really hard to see with the naked eye that they don't meet, right? And so whether it be just a little tiny tine of one of the forceps is off, it can mean that the instrument doesn't function, doesn't open. Sometimes, the tines will stick together if they're bent in a specific way. And so paying specific attention to those fine little details and the tips of the instruments, making certain they don't snag on either the towels or even the drapes are critical because that can just mean the difference between an instrument that functions and an instrument that doesn't function. And oftentimes when we try and bend those little tines back, we'll break them or we won't be able to get them back into the proper alignment. The other thing that's important, an important nuance, I think, for ophthalmology instruments is that a lot of the cannulas, specifically the cannulas that like my colleagues use to inject medicine into the eye, can get filaments in them. And those filaments can then end up in the eye and can incite inflammation in the eye and sometimes actually have to go back and be washed out of the eye with a second operation. And so making certain that there's not towels with filaments on them that can be released into the baths in which they're cleaning the instruments with is really important too.
Thank you for talking through those. What's really cool for me is, so I've worked in the sterile processing department for about 4 years. And so just seeing the instruments that you're talking about and understanding and really thinking back and thinking, wow, did I pay as much attention as those instruments deserved? And just kind of doing that personal check is really a sobering moment and probably will be for a lot of sterile processing folks tuning into this. So thank you for sharing those nuances. With those little delicate instruments comes, opportunity for easy break or opportunity for missed quality checks or missed cleanliness. And so you just spoke really well to the details that are necessary in preparing these instruments for a safe surgery. And speaking of safe surgery, the reason why I was so excited for this interview is because you were my eye surgeon. You are my eye surgeon. You're stuck with me for the rest of my life. Once a year, I get to come and see you. And so you and your sterile processing team played a really, really critical role in my health journey over the last year when I was diagnosed with ocular melanoma. And so hearing you talk about all these instruments, first of all, did you use a Manhattan forceps on me is my first question. You did. Awesome. You got to use your left hand and your Manhattan forceps. That's amazing. But, one thing that I just want to talk about for a little bit is really making that connection, like Hank mentioned at the beginning, that connection between surgeon and patient. Because I think there's a really big opportunity to shine a spotlight on the real people that are impacted by the job that you do, me being one of them. You removed my entire right eye on June 1st last year in 2022. And I just want to just walk me through, when you're staring at a patient, when you were staring at me, I'm going to talk in first person, laying on your operating room table, about to take out my entire eyeball. I know we had talked through what was going to happen. You did an incredible job at preparing Ryan and I in the short 2 weeks that I had to prepare for surgery after being diagnosed. But when you are about to save someone's life, because that's what you did for me by removing this horrible, horrible tumor, what goes through your head when you're about to make that first cut?
Yeah. So, I have this checklist that I do in my head each time. And specifically for the type of surgery that we did for you, it's, this patient's entrusting me with their life, number one. Number two, I have great responsibility to make certain that everything goes the way we need it to go. But when and my staff laugh at me because I'm super methodical. Like I say the same thing every single time I walk into the operating room. And it's funny because many of my patients are awake when I do surgery on them. And I say the same thing every time I'm operating. And it's just like my mental checklist about things I need to go through to make certain that I'm prepared, my staff is prepared, and we're ready to do the best job we can. And so in your particular case, we do 2 timeouts to make certain we're operating on the correct eye.
Thank you.
And then we prep and we drape and we do another timeout to make certain that we're operating on the correct eye. And specifically when we go to remove an eye, I look at everybody in the room in their eyes and I say, I'm removing the correct eye. And I have them look at the eye that's draped because I think it's so important that we don't want to make a medical error like that. And those are little things, but important to me because I don't want to ever make a mistake like that. And then I actually dilate the eye and look at in your particular scenario, look at the tumor and make certain that there's a tumor in the eye I'm going to take out. And then we get started. And so it's just a mental checklist and preparation and make certain that we fulfill all those steps. So when I remove an eye that has a tumor in it, I'm really careful about the fact that that tumor could either be outside the eye and I don't know it because we don't see it on a scan and we can only see it with our very own eyes, or that we don't enter the eye inadvertently because that changes the prognosis for the patient because then the tumor is no longer contained within the eye. So those are all mental checks that I go through during the process and make certain that those things don't happen because it can influence overall survival in a case like yours.
Just hearing you talk about it brings me back to that day. Yeah, which is really powerful. And I wish there was an opportunity for me to go back and watch. As strange and crazy as that sounds, I wish I could watch because the idea of removing an entire eye is just such a strange one. And I also wanted to ask about the implant placement because I now have a permanent implant. I think it's permanent. Correct me if I'm wrong.
Yeah, it should be.
Unless it crawls out of my head. But in terms of implant sizing for eyes, when you remove an entire eye, do you go in with an idea of what size implant to use? Do you have a range of implants that you just get to choose from once you understand a little bit more of the anatomy of the eye socket? How does that work?
We do. So we actually have eye sizers. They're implant sizers and they're spherical. And they have a peg on them and they have a sizing on them. So the typical range would be anywhere from about a 16 to a 22 millimeter implant that we put in. And so in the socket, once we've removed the eye and things are cauterized and we have the muscles on, they're tagged with sutures, I'll drop the implant sizer in and choose the biggest implant that I can safely fit in the socket because it gives us the best aesthetic outcome with the prosthetic. So the goal is to have an implant that's generous enough that allows you to keep a prosthetic in place. So let me back up because people think about a prosthetic eye that it's spherical and round. It's not spherical and round. It's a hand-painted large contact lens that is basically a big and plastic and it's got some concavity to it so that it can sit overlying the prosthesis, which is a spherical implant that's placed at the time of the surgery that's connected to the muscles that help move the eye. And so the prosthetic eye is not round at all. It's a big contact lens. And the prosthetic eye is not placed at the time of surgery. That's placed about 6 to 8 weeks after the actual eye removal procedure. So the implant, the spherical part that's sutured to the muscles, is what's placed at the time of the operation. And that's what we have to decide the sizing on.
Okay. And you mentioned it is attached to the muscles. So the muscles are essentially sewn into the implant. So the implant moves as the eye muscles move.
That's correct. So the implant, if you think about it like a piece of coral, it's porous and it has holes in the front face of the implant. So that the front side of the implant where I can put sutures through that are attached to the muscles that I've taken off your eyeball. And then we suture those muscles on the face of the implant so that when you turn your eye, your prosthesis will move.
As I was preparing for this interview, I was actually thinking how often since, June, I have forgotten that Lindsay had an implant, right? And Linz, I know you're not the guest on this show, but I'm curious, have you ever forgotten this, or is it such a part of you that you couldn't forget it, right? I'm just kind of curious that.
That's a really great question. And I'll give you an example. It happened this morning where I was putting my daughter's boot on to go to school and I rubbed my eye too much. And my prosthesis fell directly out of my face. It's that contact lens and it just dropped out of my head. And so that was a stark reminder that I do not have a real eye on that side of my head. But for all intents and purposes, it feels normal unless I go in a sauna and it gets really hot. But otherwise it feels normal. It creeps people out that it moves so well. And so, Dr. Melicher, thank you for being generous in the sizing of the implant, because you're right, it does make the actual prosthesis able to be thinner and give it more mobility as it couples to the implant. And I think that speaks well to the art that you spoke to loving at the beginning of this interview. It's like that fusion of surgery and art that I think is just so cool and so beautiful.
It's so cool. Yeah.
To kind of wrap us up here, I want to ask you, going back to the career conversation, you mentioned mentorship was very powerful for you in the particular field of surgery that you landed in. And, we've got a lot of folks listening who they may not have had a fetal pig moment in their life, but, this podcast might be that moment for them. And so is there anything that you would share, particularly about this type of surgery, or even, maybe we have surgical techs that are thinking hey, do I want to go to a trauma hospital? Do I maybe want to go to an eye center and, support these kind of surgeries? What would you say to folks who are looking at the future of their healthcare career to potentially go the route that you chose here with eyes?
Right. I work with a lot of staff, and I will say that you have to love what you do, because you often spend more time at your job than you do at home. And so you have to love what you do all day, every day. And you have to love who you work with, because it's so important that, my team puts up with my little nuances and they understand who I am as a person and what makes me tick. And I feel like they're my family, because they know how much I care about what I do. And that makes them care about what they do as well, I think. And so I think really enjoying who you're surrounded by and loving what you do are the most critical things about your job. But, you kind of know what makes you tick. So if you thrive on that trauma, that overnight, middle of the night, massaging hearts, bringing people back to life, chaos, then a trauma hospital is really cool for you and you'll love what you do because of it. But if that's not you, you can find a place to call home. You just want to surround yourself with people that love what they do as much as you do. And I think it will help you in your career. But you're right. One person can change the trajectory of your life in many different ways.
Yeah, not the least of which your story here with Lindsay.
You're that person, Dr. Melicher. You and your sterile processing team and your nursing team, I would be remiss if I didn't say a huge thank you to them as well, because I know that, that team makes a really, really big difference in your ability to successfully do your job.
Absolutely, they do. Absolutely, they do. And when you came back and you gave me a card to give to them, it was really one of the first times that someone's purposefully thanked I mean, many patients thank our entire team, but it's the first time that someone's really thanked that team and called them out in what they do. And so I made it a big point to walk in there and say, you guys made a huge difference in this woman's life. And the impact you may consider sometimes they might not feel as a part of a bigger team, but they really are. They're critical to what we do.
All right. Well, Dr. Melicher, thank you again for spending a few moments of your time and sharing your heart and your insight and this very important story to us of Lindsay's procedure and continued fight against all the things that want to do us harm out there, not just germs, but cancer as well. So yeah, thank you again for your time and coming on the show.
Yes, you're welcome. And thank you for having me. Thanks, Lindsay.
You're part of my family. You're stuck with me now.
And you're part of mine.
And that was Dr. Jill Melicher. Your doctor, Lindsay. So, man, what a powerful story. And I mean, we went a long ways, right? From talking to her early career through the process, covered a lot of surgical instrumentation, nuances, everything about surgeries, and obviously got a chance to spend a lot of time on your particular experience. But I got to think, that I don't know if I would use the word cathartic, but, that had to be really powerful for you in a number of different ways.
It was, not the least of which was the opportunity to talk about the impact that a simple card had on her sterile processing team. Not only has she impacted my life and her team impacted my life in such substantial ways, but I think it was really cool that she really made a big deal out of the part of the team that they are. It makes me feel good that I had some sort of influence in that for sure.
Right. Well, and the audience, didn't get a chance to hear this, but before we went on air, the both of you were talking about this is the first time that you got to see each other's faces in the virtual studio. So I thought that was pretty cool as well.
Yeah, we've only seen each other fully masked. So yeah, it was nice to see her full face, not just her nose bridge up.
That's right. Well,
the woman who saved my life. I know what she looks like now.
That's right. Yeah. Now you can actually recognize her on the street. Yes.
Exactly.
Well, that's going to wrap up our season 19 of The Surgeons We Serve. I hope the audience out there, all you clean freaks, appreciated the opportunity to hear from all those men and women in the OR suite that, sometimes we say get cranky if we get things wrong, but at the end of the day, they're out there saving lives, and we are just as important part of the puzzle as they are, but they can't do their jobs without us, and vice versa. We wouldn't have jobs if there weren't surgeons out there doing procedures. So we need each other, and we need each other on the same team to fight dirty. So I appreciate y'all tuning in here for season 19. If you're new to the Beyond Clean podcast, you're not already subscribed to us on Apple, iTunes, Stitcher, Google, iHeartRadio, et cetera, go subscribe to us today, or even better yet, download the Beyond Clean mobile app on Android and Apple. And if you've got any ideas for future guests or future season topics, reach out to us. We want to hear from you. And the best way to reach us is through info@beyondclean.net or connect to us directly through LinkedIn. And as we like to wrap up every one of these podcast episodes, we want to thank you for what you do out there each and every day fighting dirty. And we'll talk to you again soon.